Topics in ophthalmology. This diplopia is important over here. Causes of the diplopia: binocular diplopia, monoocular diplopia. Binocular diplopia means diplopia while seeing with the two eyes. It occurs when both eyes are open and eliminated when occlusion of either eye. So that means this diplopia is there when you see with both eyes, and if you keep hand on one eye, then the images will be normal if you see with other eye. Monoocular diplopia means it occurs with one eye open and it remains with occlusion of unaffected eye. Monocular diplopia means with only one eye and occlusion of unaffected eye. If you occlude the normal eye, then from the abnormal eye, you see the image that is called monocular diplopia. Binocular diplopia with two eyes. So, what are the conditions where you see binocular diplopia with two eyes? Decompensated congenital strabismus, ocular motor nerve dysfunction like third nerve palsy, fourth nerve palsy, sixth nerve palsy, myasthenia gravis, botulism, neuromuscular junction disease. This is important. Myasthenia gravis, botulism, mechanical process like muscle restriction, entrapment. Supranuclear causes are skew deviation, dorsal midbrain syndrome. If you remember three, it's enough. One, two, three. Ocular diplopia, optical errors, yeah, refractive errors, astigmatism with one eye problems. These are all one eye problems. Mechanical processes like dislocated lens, post-operative sequel of cataract surgery, peripheral laser iridotomy. Okay, so mechanical process means there's a mechanical problem in the eye. Like if the lens is pushed down or after post-operative period after cataract surgery and peripheral laser iridotomy. Serious ocular emergencies. So, what are the conditions which require urgent ophthalmological consultation? So, we should know what are the ocular emergencies, and because this is like the first priority, and we should never ignore these things when there is sight threatening and life threatening. So, sight threatening means when the patient can become blind if we don't treat immediately. So, these conditions are lid laceration, globe rupture, chemical burn, corneal ulcer, gonococcal conjunctivitis, acute iritis, acute glaucoma, central retinal arterial occlusion, intraocular foreign body, retinal detachment, endophthalmitis, genital arteritis. So in this sight threatening, the most important here is see gonococcal infection is very very important because this can even occur in the newborn baby if the mother is untreated for the gonococcal infection. Gonococcal is an STD infection, right? So if the mother has delivered a child, so that child can have gonococcal conjunctivitis. How means it is like the baby passes through the birth canal and the birth canal is contaminated, so the baby gets the infection because this is the infection of the genital area. Acute iritis, acute glaucoma, all medical emergencies. Acute iritis, this is also very important. Acute glaucoma, raised intraocular pressure, patient will be in very severe pain, mid-dilated pupil, central retinal arterial occlusion. So in this there is cherry red spot, and there is this can occur even in transient ischemic attack. So you have to do a thrombolysis in this patient. Central retinal arterial occlusion, that some artery is getting occluded, which is supplying to the eyeball. This is very important. Retinal detachment is important. Endophthalmitis is important. Globe rupture is important because if one eye is ruptured, then other eye can also become like a sick eye, and both eyes will lose their vision ultimately. So life-threatening. What is a life-threatening ocular emergencies? Means the patient is having the danger to his life, not only the vision but also his life. So here proptosis is there. So if, when you see the patient is having proptosis, so proptosis is like the eyes are protruded out. So you can see proptosis in hyperthyroidism also. But here it is telling that when you see proptosis like protruded eyes, you have to rule out the cavernous sinus fistula or thrombosis. Renal of third palsy with dilated pupil. So this is very, very important because third nerve palsy, there is palsy of the eye muscles. Okay, so the eye is out and down, down and out. That's the position of the eye. And here in the third nerve palsy, if it is normal pupil, there's no worry. But if the pupil is dilated, then that you have to rule out intracranial aneurysm or external compressive neoplastic lesion. Papilledema, it is important to rule out because this is elevated intracranial pressure. Papilledema is very, very important. You have to do, if the patient is having meningitis, you have to do the eye examination in detail, like retinal examination. This is to rule out the papilledema because papilledema is very important. And if you do lumbar puncture while the patient is having this papilledema, then there will be like uncal herniation. That means suddenly the uh, brain parenchyma will uh, collapse and come down. That's like a suction effect. So that will compress all the medulla oblongata, midbrain structures and all that. So, so medulla has got the respiratory syndrome. So the patient can die with the respiratory arrest. So this papilledema ruling out is very, very important. Orbital cellulitis, infection of the eye, which is this orbital cellulitis is like severe. We have to treat immediately. Leukocoria, white pupillary reflex. That is, if you see a child with a white reflex, then you have to rule out the retinoblastoma. So in a normal person, if you check the pupils of both eyes, while doing while using the ophthalmoscope to check the retina, a red reflex should come out. The red light is actually nothing but the reflection of the retina because retina is vascular. So if the retina is actually white here, so that means that the patient is having retinoblastoma and you have to rule out that. Which this is important now. Preceptal cellulitis, orbital cellulitis. Preceptal cellulitis, it is infection of the soft tissue anterior to the orbital septum. Etiology, I will share a PowerPoint presentation with the images also because seeing the images is also very, very important. Preceptal cellulitis, it is infection of the soft tissue anterior to the orbital septum. It usually follows the periorbital trauma or dermal infection. Clinical features, see the table 6 of OP 10. Orbital cell. Okay, so let's see preceptal cellulitis first. So preceptal cellulitis. So this is like it has not spread to the all orbit. Orbit is like the complete eyeball. It's like ball shape, right? So complete eye, like front part, back part, side part of the eye. So that's called as orbit. So that's why orbital cellulitis is dangerous because it affects the eye completely from anterior part to posterior, both lateral parts, the globe, all over our globe, that is affected in orbital cellulitis. But in the preceptal cellulitis, it means that the uh, inflammation of the membrane, you can think as it has a membrane which covers the orbit tissue anterior to the orbital septum. So anterior to the orbital septum, that means one layer ahead of orbit is infected in preceptal cellulitis. So what is there? Fever may be present. This is like the first step to the severe infection. So you can see like mild infection in this case. Fever may be present, lid edema, it can be moderate to severe. Conjunctival injection, there is no swelling of the conjunctiva. Chemosis, it is redness of the eye, okay? Chemosis means inflammation or the redness of the cornea. Chemosis is not there, proptosis is not there, eye swelling is not there, pain on the eye movement is not there. This is very important. Pain on the eye movement is super, super important. Uh, Ocular mobility is normal, vision is normal, retinal relative afferent pupillary defect. So this is relative afferent pupillary defect. Leukocytosis, it is moderate because it is an infection. Leukocytosis is there. You can see the elevated WBC. ESR is also normal or elevated. Okay. So in addition to this preceptal cellulitis, you can see that the patient is having some of the skin infection. Orbital cellulitis, this is like a very severe type of the infection, and this is a medical emergency. So how will you, let me complete this, preceptal cellulitis, how will you complete it? So this is mostly inflammation of the conjunctiva, fever is there, leukocytosis is there, ESR is elevated. Okay, lid edema is there. Upper lid is swollen, the patient is having fever. If you check the blood work, then WBC is elevated and the ESR is elevated here. So what is antibiotic? Um, so most often the cause is like the H influenza in the children, staph aureus or streptococcus in adults. So staph is always the culprit in the adults, staph, strepto, and H influenza in children after viral infection, because they rub their eyes after any viral infection. Some viral infection will have the irritation of the eyes, right? So in that case, example is just like amoxicillin, clavulanic acid. Treatment, it is amoxicillin plus clavulanic, as simple as augmentin, can save the life. If it is very severe or if the child is less than 1 year, then you have to treat it as orbital cellulitis. So if the child is less than 1 year, then you have to treat it as this only. So orbital cellulitis, what are the things that you see in orbital cellulitis and how it is occurring? So this orbital cellulitis, it is inflammation of the orbit contents posterior to the orbit septum, common in the children, elderly, and immunocompromised. Etiology, it is after the sinus infection, facial infection, tooth infection, trauma. Can also arise from the preceptal cellulitis. So all the things in the face like sinus, facial infection, tooth infection, or trauma can lead to the orbital cellulitis. Orbital cellulitis can be clinically indistinguishable from the preceptal cellulitis. For the equivocal findings, difficult examination, presence of the nasal discharge, you have to do CT scan or MRI of the orbit or sinuses. So clinically, you can differentiate whether it is orbital cellulitis or preceptal cellulitis. So in orbital cellulitis, what can you see? Everything is like very, very severe here. In orbital cellulitis, we saw only two clinical features were there, okay? But here, clinical features two and in labs two were elevated. But in orbital cellulitis, you can see everything is severe here. Fever is present. It is a very high fever. Lid edema, it is actually very severe. Eye is actually so swollen. Conjunctival injection is present. That is, redness is actually overall. Redness of the conjunctiva, redness of the cornea. Proptosis is there. The eye is actually bulging out here. Pain in the eye movements. This definitely signifies infection. Pain on the eye movement. Ocular mobility, it is decreased. Ocular mobility, it is decreased here. The patient can't move the eyes here and there. Vision, it is diminished or diplopia may be there. So the patient is actually having decreased vision. The patient is seeing the blurry vision, and until finally that the patient's vision completely drops down and the patient can't even see anything. So this patient is more likely to get blind, and more than ever, this patient can go in sepsis and septic shock also. We don't want that to occur. Vision is diminished, diplopia is there, relative afferent pupillary defect may be seen if it is very severe. Leukocytosis, elevated WBC, it is like very severe rise in the WBC. ESR is elevated, sinusitis is the dental abscess is there. And this is done. I will just tell everything in superficial few lines about this. So dry eye syndrome means that the eye becomes so dry that the patient will have the foreign body sensation, blurred vision, tearing, and eye pain. So basically, this dry eye, it can be seen in this is actually basically autoimmune destruction of the um, autoimmune destruction. This is autoimmune destruction of the lacrimal gland. It can be like autoimmune, like as Sjogren syndrome or non-Sjogren syndrome. Non-Sjogren syndrome means it can be trachoma or chronic use of the contact lens, seventh nerve palsy, anticholinergics, antihistaminics, diuretics, vitamin A deficiency, topical medications used with preservatives, eyelid abnormalities. So what is the investigation you do? You do fluorescein staining, streamers test. This is very important. Streamers test will show decreased distance, and fluorescent or the rose bengal staining will actually show that there is surface is damage, and there is less production of the tear. The basically our tears protect our eye. So if that is not there, the patient will have itching sensation in the eye. Treatment, it is a medication. You give artificial teardrops. So teardrops are available in the pharmacy, so they can use the over the counter teardrops. And ointment, it is like very thick. It will be very thick, so this is just at the bedtime. So they should not use it more than 4 to 6 times. Mild short course of the corticosteroid can be used. Omega-3 fatty acids can be used. For moderate to severe cases, you can even try the cyclosporin. Cyclosporin is like immunomodulator for the severe cases. Epiphora means excessive tearing, like patient is having tears coming out from the eyes all the time. So that can be due to some dust, stress, like cold wind, pollen, or any foreign body coming in the eye. So you have to check the patient here in the slit lamp examination, and you will know from there. Dacrocystitis, it is inflammation of the lacrimal sac. So chronic infection. This is the chronic infection. Dacroadenitis means it is actually seen in the children. So here antibiotics is enough. Because in children or in the young adults, if it is like some infection, you can just give the antibiotics, warm compresses. That's it. Pain, swelling, discharge is there, redness is there. Just like any infection, this inflammatory findings. Ptosis is drooping of the upper lid. We can see this ptosis in Bell's palsy. Trichiasis means eyelashes actually turn inwards and it is irritating the cornea. So this will lead to corneal inflammation. Entropion, lid margin is turned inwards. Ectropion, lid margin is actually folded outward. Hordeolum or the stye. So let's do this. Hordeolum, stye, or chalice, and differentiating them is actually very important because there is only a minute difference between these two. Hordeolum or stye, acute inflammation of the eye gland. So here it is infection of either meibomian gland, internal lid, or gland of the Zeiss or mole, internal lid or external lid. So any lid can be affected here. So infection agent, it is staph aureus, painful red swelling of the lid. So basically here the staph aureus infection, which is staph aureus, it is present in our hands. So basically if you rub a lot, you can put the infection in your eye. So you can have the painful red eye swelling of the lid. So this is can be treated with the warm compresses, lid care, because not touching the bare hands, washing the hands, keeping some hygiene, eye hygiene, warm compress, lid care, like using some mild shampoo to clean the eyelashes. gentle massage. Topical antibiotics are actually typically ineffective. So topical antibiotics are typically ineffective, usually resolve within 2 weeks, but may require incision and drainage. So it is telling that topical antibiotics are not effective. It will take 2 weeks, it will disappear on its own. Chalazion, it is chronic granulomatous inflammation of the meibomian gland. So this is super important. Meibomian gland, chalazion. CC, chronic granulomatous inflammation. Chronic chalazion. Meibomian gland is infected. So you should remember this meibomian gland preceded by the internum hordeolum. So it is telling that it is affecting the internal hordeolum. It's telling, right? So it is affecting internal lid, inner part of the eye. So acute inflammation in inflammatory signs are absent. Differential diagnosis: basal cell cancer, sebaceous cell cancer, meibomian gland cancer. Warm compress you have to give. If there's no improvement after 1 month, consider incision and drainage. Chronic recurrent lesions must be biopsied to rule out the malignancy. Here, for both of them, they are telling warm compresses. They don't want to give antibiotics to give antibiotic. They just want the warm compress to just decrease the basic idea is to give warm compress, decrease the inflammation, and no need to give any antibiotic according to them. If the there is no improvement after 1 month, then incision and curettage can be done. Incision and curettage is like doing the incision and scooping out the contents. Blepharitis, it is an inflammation of the lid margin. The eyelid margin is actually inflamed here. Xanthelisma is actually yellowish lipid deposits near the eyelids. That is called as xanthelisma. Conjunctivitis means inflammation of the conjunctiva. The white part which we see is conjunctiva. So the etiology is like infectious or non-infectious. So let's complete this conjunctivitis. So conjunctivitis is inflammation. Infectious, it is bacterial, viral, chlamydial, gonococcal, fungal, parasitic. Non-infectious, it is like allergic, atopic, seasonal, contact lenses. Contact lenses can also cause irritation and cause GPC, contact lens errors. Toxic, it is like irritant, dust, smoke, irradiation. Secondary, it is like dacrocystatic, dacroadenitis, cellulitis, and systemic inflammatory disease. So how will this basically conjunctivitis means redness of the eye? So conjunctival injection is there, chemosis is there, uh, itching, foreign body sensation is there, this discharge from the eyes, crusting of the lashes in the morning. So this is in mostly in the conjunctivitis that the eyelashes are stick together in the morning and the lid edema is there. Here, lymph nodes may or may not be there, preauricular or submandibular lymph nodes, follicles, pale lymphoid elevations of the conjunctiva. Follicles are elevated, overlain by the vessels. Papillae can be seen, cobblestone appearance of the conjunctiva. So these things you can see in the eye examination. Allergic conjunctivitis. So allergic conjunctivitis, there is cold there is cold, or if the patient is known case of asthma, running nose is there, dermatitis, the patient with dermatitis can also have this. Hay fever patient will also have this ocular pruritus. Some itching is there in the skin. Some underlying skin conditions are there which will also lead to itching. Allergic means there's always pruritus present. Small papillae is there, chemosis, redness, thickening, eyelid is erythematous. Treatment. What is the treatment of allergic conjunctivitis? So avoid the allergen. Cool compress, not the hot compress. Okay. Cool compress, non-preservative, preserved artificial tear drops, topical antihistaminics. And also topical or topical antihistaminics, oral antihistaminics, muscle stabilizer, Promolin, ketolidine, olapatadine. So these are like topical eye drop form of mast cell stabilizers, topical corticosteroids. You just have to remember antihistaminics, cool compress, topical mast cell stabilizer, topical corticosteroids. GPC is seen in contact lens wearers. Atopic conjunctivitis, late onset in the adolescence or the early adulthood. Intense ocular pruritus, tearing, burning, redness, blurry vision, photophobia, full body sensation. This will become thick and intermittent swelling of the eyelids, conjunctival chemosis. Severe cases, it will lead to fibrosis. Okay, then this is vernal conjunctivitis. Vernal conjunctivitis, it is large conjunctivitis. Large conjunctivitis, there is cobblestone appearance of the superficial palpebral conjunctiva with the corneal shield ulcer. Limbal follicles are there, and keratitis is there. It is seasonal. It is seen in warm weather. Occurs in the children also. Image is actually showing conjunctival hyperemia, redness. See, you can see conjunctival hyperemia. Conjunctival hyperemia means redness of the eye. You can see that the all white part is actually red here. Ciliary flush means only to the sides. Only near the sides it's red. So what do you give here? Vernal conjunctivitis, seasonal. This is like seasonal conjunctivitis. Cobblestone appearance is there. Here and the treatment here is teardrops, topical steroid. Because see, this is kind of allergic thing. So, and the body is the eye. If you check the eyelid, it will show the papillae, large papillae. So, to treat that, you have to give topical steroids to decrease this papillae. If this is not respond, this papillae are not responding to topical steroid, even after you increase the frequency and all that, but then you have to start topical cyclosporin, and this has to be by the ophthalmologist also. Viral conjunctivitis, it is like a pink eye, like when you have cold cough, that time you can have this viral conjunctivitis also. Pain and the swelling of the eye, serous discharge, lid edema, follicle, pseudomembranes, subepithelial corneal infiltrate is there, a preauricular lymph nodes that are palpable and tender, initially unilateral. Treatment, it is self-limiting, cool compress is present, and topical lubrication is there. Proper hygiene should be maintained to prevent the transmission. So they should not rub the eyes. If you rub the eyes, then it is more likely to get any bacterial infection. So viral conjunctivitis, it comes with the viral infection. Only clear serous discharge is there from the eyes. Lids are like edema, swollen eyes are there. Follicles are present. It can be unilateral or bilateral. Bacterial conjunctivitis, it is purulent discharge, lid swelling is there, papillary conjunctival injection, chemosis is there. So purulent discharge, it is pus. Purulent discharge is like the infected pus discharge is there from the eye, and lid is swollen, papillae is there. The conjunctival injection, the red conjunctiva is actually very red here. So the culprit here is Staph aureus, Streptococcus pneumonia, H. influenza, Moraxella catarrhalis. Treatment, topical broad spectrum antibiotic. You give topical antibiotics like Ciplox drops, Oflox drops, eye drops. Uh, If it's still it's not responding, then you will give the systemic antibiotics if needed. Gonococcal and chlamydial conjunctivitis. This is super important. It is after the STD infection. Especially it is seen in the newborn. Okay, caused by the Neisseria gonorrhea, chlamydia trachomatis, affect sexually active individuals, neonates. It's called ophthalmia neonatorum in the first 5 days of the life. So when the baby is in the hospital, then that time only these things will be there. If it is caused by the gonorrhea, it is going to yeah. If it is due to the gonorrhea, you will see it in the first 5 days of life. That means when the mother is in the hospital, that time only this thing is visible. If not, 3 to 14 days of life when it's caused by chlamydia. So chlamydia, even after discharge, like within the first week of visit, you can see this 14 days, till 14 days, it can occur. Even prophylaxis with erythromycin 0.5% ointment. So to prevent all this, you have to give erythromycin 0.5%. Document or suspect cases of gonococcal conjunctivitis should be evaluated by an ophthalmologist for an intense IV and topical treatment. Chlamydia causes the trachoma and inclusion conjunctivitis. It's a different serotype. Severe form is trachoma here. Trachoma is the leading cause of blindness in the world. Severe keratoconjunctivitis. It is like first conjunctiva is in only there is redness of the conjunctiva here, but in trachoma there is keratoconjunctivitis. That means the white part of the conjunctiva and the cornea, the black part, that is also severely infected and inflammation is there. That leads to corneal abrasion, ulceration, scarring. So treatment, how will you treat this? Oral azithromycin plus topical tetracycline. Okay, so the next important topic here is episcleritis and the sclera. Sclera, it is actually the white fibrous outer protective coat of the eye. So the white thing that you see in the eye, that is the sclera. So the inflammation of this sclera, inflammation of the sclera in the sense the front part which you see white, the back part and as well as the sides part. So all over the globe, eyeball from 360 degrees. The episclera is a thin layer of the vascularized tissue between the sclera and the conjunctiva. Thin layer of the vascular tissue. So episcleritis, it is a immunologically mediated inflammation of the episclera. One third, it is bilateral. So basically, it is simple and nodular, idiopathic, and mostly associated with the collagen vascular diseases, infection like herpes zoster, herpes simplex, syphilis. Clinical features may have some discomfort, pain with the red eye, diffuse injection of radially directed vessels. Is there chemosis? Is there small mobile nodules? Is there treatment? It is and generally self-limited, recurrent in two-thirds of the cases. Topical steroids. You need to give topical steroids, oral NSAIDs. So to treat the inflammation, you are giving NSAIDs. Then and again, the stronger form is like topical steroids. Self-limiting. It is generally self-limiting. If it is recurrent, then you have to do systemic workup because episcleritis and scleritis, this is associated with inflammatory bowel disease. So you have to keep that thing in the mind. So this box is saying that to differentiate between the episcleritis and scleritis, place a drop of phenylephrine in 2.5% in the affected eye. Re- Re-examine the vascular pattern 10 to 15 minutes later. In episcleritis, the episcleral vessels should blanch with phenylephrine. So basically, it is telling that the episcleritis, it will blanch with the phenylephrine. That means vasoconstriction is there in this redness. These episcleral vessels will have vasoconstriction due to phenylephrine. Scleritis, it is complete inflammation of the white part of the eye. So this is very, very serious thing. So this is like, this can be unilateral, classified as anterior. Anterior means front part of the sclera, posterior part of the sclera. Anterior scleritis pain is there radiating to the face, and it may cause scleral thinning. In posterior scleritis, it is rapid progressive blindness is there, may cause exudative retinal detachment also. So this scleritis is commonly seen in the women and elderly in SLE, rheumatoid arthritis, ankylosis, spondylosis, TB, sarcoidosis, syphilis, granulomatous things, metabolic things like gout, thyrotoxicosis, infectious staph, strepto, pneumococcal, herpes zoster, chemical injuries, physical agents. So basically, this scleritis is like very, very important, and this is like very severe form. The patient is having severe, deep pain, deep, boring pain is there. Photophobia is there. Red eye, decreased vision. This is actually a kind of medical emergency, so we have to pay attention to this. You can't ignore this patient. Like, come after 5 days, come after a week. No, you have to see and treat immediately. Pain is the best indicator of the disease progression. So the severity of the pain indicates that how bad the patient is having that disease. Inflammation of the sclera, episclera, conjunctival vessels. It may have anterior chamber cells and flares, corneal infiltrates, scleral thinning, scleral edema. Sclera will have purple violaceous hue, best seen in the natural light due to thinning of the scleral fibers. Failure to blanch with topical phenylephrine. We saw that here. Topical phenylephrine. If you put, there's no blanching. Scleromalacia purpurans, it is seen in rheumatoid arthritis. So this is time perforate also strongly associated with the rheumatoid arthritis. Traumatic perforation can occur can easily occur. So gentle eye examination should be done in scleromalacia perforans. This box is important. So treatment, vision threatening. So urgent referral to ophthalmology. So basically, why this is very, very important, because see, most of the times eye complaints patients are seen by the GP, general physicians, or the or the eye technician. I can say eye technicians, and also in some places they see, because the doctor is like always booked. So if you see such patients, you should immediately refer the patient to ophthalmologist. Irrespective of anything, the ophthalmologist should she see this patient. This is ophthalmic emergency. So life-threatening indicator of the poor systemic disease. So that so it is like poor systemic disease means that the patient is having poor systemic disease, like the rheumatoid arthritis is uncontrolled, the SLE is uncontrolled, the ankylosis spondylosis is uncontrolled, the TB is uncontrolled, syphilis is uncontrolled, or the patient is having unrecognized autoimmune condition like rheumatoid arthritis is presenting first time in this way. And if you do further testing, you will see that the patient is having rheumatoid arthritis. And so you just, or because it's an autoimmune condition, you have to treat it immediately. So this will also improve. Systemic NSAIDs, systemic steroids, systemic immunomodulators. So here, because this is autoimmune conditions, you are not giving anything topically. You are treating it as systemic only in tablet form. NSAID tablet, steroid tablet, prednisolone tablet, systemic immunomodulators like cyclosporin or anything. Treat the underlying etiology, treat the cause, look for the cause. Okay, now the next one is This is here. So here, endophthalmitis and the vitritis. Endophthalmitis and the vitritis, it is intraocular infection. So in the eye, endophthalmitis it and vitritis, infection of the vitreous humor, the liquid in the eyeball, that is called as a vitreous humor. And endophthalmitis, it is complete inflammation of the eyeball, all the layers you see, scleral, corneal, from front to back, all over the eyeball, it is inflamed. So this is like super infection. So this is infection is like acute, subacute, or chronic. So most commonly post-operatively, like the risk following the cataract surgery is less than 0.1% due to penetrating injury, endogenous spread, intravitreal injection, bacterial or fungal. So here all the layers of the eye is involved. The eye completely from front to the back to the end, everything is infected here and everything is inflamed here. So you see all kind of symptoms. Painful red eye, painful red eye, photophobia is there. The patient can't see the light. Eye discharge is there. Severely reduced vision. The patient can't see anything. This patient is going to get blind here. Lid edema is there. Proptosis is there. Corneal edema is there. Anterior chamber is having edema. Cells are present in the anterior chamber. If you see the anterior chamber, there is pus present in the anterior chamber. Hypion is there. Reduced red reflex. Reduced red reflex means you can't see the retina. Retina is having red reflex. Why? Because there is pus in front of that, right? So because of that reason, there is red reflex is reduced here. May have the signs of the rupture of the globe. So if not treated, this patient will have ruptured globe. Why ruptured globe means this inflammation is so bad, it will expand, and if it expands, there is risk of rupture of the globe, right? So severe subconjunctival hemorrhage, chemosis, hyphemia, sudden decrease in the intraocular pressure. So this is ruptured globe, how it present. Sudden redness everywhere, and sudden drop in the intraocular pressure means rupture. After rupture, the sudden drop of intraocular pressure, ocular emergency, we presenting with the vision loss. So if the vision is there, means that okay, there's some chance you can save the patient's vision. But if not, it's an ocular emergency. Lumbar puncture should be done. Admit the patient, immediate vitrectomy, intravitreal antibiotics.
In progress.
Okay, so now next topic. Let's go to next topic. So yes, I was doing this endophthalmitis and vitritis. Vitritis is the infection of the vitreous humor. Endophthalmitis, it is like the all over all the eyes actually infected here. Remember to inquire about the tetanus status in post-traumatic endophthalmitis. Okay, so ask about the tetanus status. So here you will you will admit the patient immediately, and immediately vitrectomy is that you are actually removing the vitreous humor, and you are infected vitreous humor you are removing, and you are instead of the vitreous you are putting intravitreal antibiotic. You are injecting the antibiotics in the vitreous humor to prevent the loss of the vision. And vitreous tap is actually sent for the culture and sensitivity. Then intravitreal antibiotic you are giving. Topical antibiotics also you do. So retina, in this retina, CRAO. So this is important. CRAO. It is occlusion of the blood vessel following uh, occlusion of the blood vessel. So the any blood vessel will get occluded, and it will stop the blood flow to the retina. So it can be like a big artery, or it can be a branch of the retinal artery. So what will happen is that if there is any thrombosis, retinal artery occlusion, it is usually with thrombosis. Okay, any thrombus, or the thrombus will come from any site that's emboli from the carotid arteries or the heart, erythema, endocarditis, valvular disease. So emboli from that places can come and cause CRAO. CRAO will have cherry red spot, giant cell arteritis or temporal arteritis, sudden painless loss of the vision with the severe monocular loss of the vision. So here this CRAO, it is the cause, sudden painless loss of the vision. The patient will not have any pain, but the patient will be like a curtain has fell in his eye and he cannot see from that eye at all. Sudden painless loss of the vision. Severe loss of the vision is that the patient can't see the hand in front of him. Retinal relative afferent pupillary defect in the CRAO or large branch arterial occlusion. The patient may have experienced transient episodes in the past. So TIA, transient ischemic attack, like for some time the patient had loss of vision, but it improved within an hour. So that is called as TIA, amaurosis fugax. Cherry red spot is important. The fundoscopy is important here. Retinal edema is there. Cotton wool spots are there. Cholesterol emboli, Hollenhorst plaque. This is important. So ocular emergency, restore the blood flow immediately. You should do massage of the eye. You should actually massage the eye, compress the eye with the hand for 10 seconds and release for 10 seconds and repeat for 5 minutes. And we could to dislodge any embolus, decrease the intraocular pressure. So how do you decrease the intraocular pressure? You give topical beta blocker, IV acetazolamide, IV mannitol, drain the aqueous fluid from the eye. YAG laser embolectomy. If you see an emboli, you do in embolectomy because there is a thrombus here, so you do thrombolysis. Intraarterial or in IV thrombolysis, you do hyperbaric oxygen therapy. CRVO or branch retinal vein occlusion. This is the second most frequent cause of the retinal disorder after the diabetic retinopathy. So diabetic retinopathy is actually the first common and thing. Then CRVO is the second most frequent vascular retinal disorder. Cause is actually not known. Idiopathic. Exact cause is not known. That idiopathic retinal artery transforms to the artery into the rigid structure impinging upon the retinal vein as they shade the common sheet. Predisposing factor is like atherosclerosis of the vascular disease, hypertension, diabetes, glaucoma, hyperviscosity, sickle cell disease, polycythemia rubra vera, lymphoma, leukemia, OC pills, diuretics, painless monoocular, gradual loss of the vision. So this is the cause of chronic loss of the vision, gradual. Most of the time it is gradual or it can be very sudden also. Relative afferent pupil defect is there, fundoscopy, blood and thunder appearance. So this CRVO, if you see the retina, you see the blood and thunder, blood everywhere. You see blood here in the retina. So in the retina, there is blood everywhere. So diffuse retinal hemorrhages are there. So how will you do it? Treat this laser photocoagulation and anti-VEGF. What is glaucoma? Glaucoma is actually progressive, irreversible pressure-sensitive optic neuropathy involving the structural changes of the optic nerve. So the pressure in the eyeball, it is so high that it is putting the some pressure changes are there in the optic nerve. Optic nerve is getting compressed with that. So this is irreversible. So the eye pressure raises so much that this irreversible pressure is present. Okay, so for this glaucoma, you do slit lamp examination, visual acuity testing, ophthalmoscopy, tonometry is super important here to measure the intraocular pressure. You do perimetry because the vision loss can be there, tunnel vision will be there. OCT to check the nerve, retinal nerve, optic nerve checkup. Okay, so here you can see there is optic nerve head damage. So here cupping pallor and cupping of the optic disc, concentric enlargement, superior expansion, advanced cupping. So basically, this cupping, it is irreversible. Optic nerve is getting damaged. So if the nerve gets damaged, you can't repair it again. So primary open angle glaucoma, this is important. Primary angle closure glaucoma, this is important. So primary open angle glaucoma, it is actually the most common type, unobstructed open angle. The angle of the eyeball, uh, yeah. So this is the angle I will show here. This is normal open angle, the normal aqueous flow. So what is happening here is that the fluid in the eye, the aqueous flow, it is actually going from here and here, and it get absorbed from here, from this side. Okay, so here what it is telling is that the angle is open, there is nothing obstructing the angle. So angle is open, but still there is a glaucoma. So insidious and asymptomatic is there. Screening is critical for early detection. So intraocular pressure of more than 21, age of more than 40 is at risk, and by 80 years it is 10% risk is there. African descent, familial history, if the his family history, then you should check the patient. These patients are at the very high risk in central cornea. Myopia, diabetes, hypertension, hyperthyroidism, chronic steroid use. Clinical features asymptomatic initially, insidious, painless, gradual rise in the intraocular pressure due to restriction of the asymptomatic. The patient initially will not have any symptoms because this angle flow, it is open, angle is completely open. So, but still the intraocular pressure rises and rises. Patient is not having any pain, gradual rise in the intraocular pressure, restricting the aqueous flow. The aqueous flow is actually not going this, the flow of the aqueous humor is not going bilateral, but usually asymmetrical. Earliest sign is optic disc changes. So this thing will get detected only by the routine eye examination. When you do it in detail, the you will know that the patient is having some vision problems. So you do a perimetry for that thing. The perimetry will show that optic disc changes, increase in the cup disc ratio, increase in the cup disc ratio, significant cup disc ratio asymmetry between the eyes, thinning, notching, flame-like hemorrhages, resected peripapillary atrophy, visual field loss, slow, progressive, irreversible loss of peripheral vision. Treatment, it is decreasing the intraocular pressure by increasing the drainage or decreasing the production of the aqueous humor. To increase the aqueous outflow, to increase the outflow, because the outflow is not proper here, so we want to increase the outflow, or we want to decrease the production of the aqueous humor here. So there are two ways we can treat this. So increasing the outflow, how will we increase the outflow? Topical prostaglandin analog, topical alpha 2 adrenergics, topical cholinergics or parasympathomimetics. Decrease aqueous production, use topical beta blocker, topical oral carbonic anhydrase inhibitors like acetazolamide, a topical alpha 2 adrenergic, laser trabeculoplasty to open the trabecula so that the aqueous flow can be there. Cyclophotocoagulation in order to achieve selective destruction of ciliary body. Trabeculectomy, creation of a new outflow tract from anterior chamber. So trabeculoplasty, it is like opening a way. Trabeculectomy, it is like creating a new way. Minimal invasive glaucoma surgery, tube shunt.